Good evening, friends. Greetings from Asian Institute of Gastroenterology, Hyderabad. I am Dr. Sundeep Lakhtakia, and today I would be speaking in this postgraduate class on upper GI bleeding. I hope you are all fine and safe during these testing times, and take care of yourself and your family. In the next group of slides, I would be speaking on mainly non-varicose upper GI bleeding. And what's the practical approach to this? And these are the learning objectives that we'll have in this session of lecture. When we say upper GI bleeding, what are the resuscitation measures that have to be taken, including risk assessment and pre-endoscopic management? What's the goal of transfusion? What is the management in patients who are on antiplatelets and anticoagulants? Very common, especially patients who have heart disease or neurological disorders. What is the role of urgent or emergent endoscopy? Should we do it quickly as soon as the patient comes to the hospital, or should we wait till he improves? What are the various treatment modalities available, both endoscopically and non-endoscopically? And how should we manage these patients once we have treated them in the hospital or on an outpatient basis? So these are 6 learning objectives that I will address to in next half an hour or so. Let's go one by one. Before we start anything, we should keep in mind what are the likely differential diagnoses that are in the mind when a patient with GI bleed approaches. When you say differential diagnosis, then we keep in mind what are the likely sources and what are the diagnoses which we cannot afford to miss. Second, and equally important, is risk stratification. What does it mean? That means how sick is the patient? Can we wait for another day to do endoscopy or start the treatment, or should we start the treatment straight away? Does this patient need to go to the ward or ICU, or need not be admitted? It also tells us when and at what time should endoscopy be considered. So before I go further, this theoretical slide I would re-emphasize here what are the differential diagnoses of patients who come with upper GI bleed. The 2 most common causes, peptic ulcer and gastroesophageal varices disease. Over many decades, peptic ulcer was always the first cause, but over last decade or so it has come to number 2 and varices have become number 1. Other causes which can cause bleed are esophagitis, gastritis, erosions and duodenal erosions, Mallory-Weiss tear. A very classical history comes up when a patient retches before he starts vomiting, blood, vascular ectasias, neoplasms which can occasionally present as bleed, Dieulafoy's lesion, a lesion which often hides itself and not manifest in first go or second go also. So sometimes the patient has recurrent upper GI bleed and endoscopy is not finding anything. It is better to repeat endoscopy sometime later or at the next sitting when he had a next session of upper GI bleed. Sometimes few sessions of bleed pass down and then you pick up these lesions. Aortoenteric fistula, rare diagnosis, but should be kept in mind in patients who have a past history of any vascular surgery in the upper abdomen, and sometimes bleeding from the bile duct or from the pancreatic duct in patients who have biliary or pancreatic disorders, where this can precipitate as or present only as an upper GI bleed without manifesting of the primary disease. So these last few diagnoses are rare, but one cannot afford to miss, because once you diagnose them, you can actually treat them quite easily. And how do we go forward? Obviously, each patient requires a good history and a physical examination. It is must, whatever stage of clinical practice we are in our gastroenterology, we cannot do away with history and physical examination. In fact, I must say that at least 50 to 60% of the diagnosis can just be made on history, at least for GI disorders. Physical examination adds another 10 to 20%. So about 60 to 80% of your patients you can diagnose just by physical examination and history. And that should never be ignored or avoided. We have fantastic levels of investigations available, high techs, but these basic things can help us in your common chamber practice or in a peripheral practice. And what do you ask in history? What are the likely localizing symptoms that patient has? I will just enumerate it, but I'm sure since most of you are postgraduates, you would be knowing about it. All textbooks and clinical examination books mention about this, but nevertheless I would just repeat it once again. Apart from that history of prior GI bleed, which points us towards either varicose bleed or maybe a vascular bleed, history of drugs, especially non-steroidal anti-inflammatories, ibuprofen, paracetamol causes less, but aspirin and ibuprofen are one of the commonest causes. Any past history of liver disease, which will be manifest by various signs and symptoms, vascular disease, aortic valvular disease or chronic renal failure, abdominal aortic aneurysm repair, radiation exposure, and family history of GI bleeds. And physical examinations, obviously blood pressure and pulse rate is paramount. Even if the patient looks stable and is walked in, you may miss that crucial clinical clue when the patient is about to deteriorate. Suppose he comes stable and walks in and you take a blood pressure, he has normal blood pressure but he has tachycardia, which tells you that something is missing. He won't go to the level of shock or diaphoresis or sweating. Just tachycardia itself gives us a clue, okay, I have to look more carefully, maybe observe him overnight in emergency or in the ward before he deteriorates, because if it will be a disaster that if you see a patient in the clinic and send him off to come next day and he has a bleed at home and he dies or has a major catastrophe, you will not feel happy next day. So never ignore those small clues which will guide you for further treatment. Postural hypertension is one of them. Tenderness, skin and oral examination. Oral examination tells you about the presence of pallor. If it is there, that means the anemia related to GI bleed is more chronic and not a overnight event or a very recent event. And sometimes you see those petechial spots which will tell you that thrombocytopenia is there, or vascular malformations either in the tongue, lips, nose, nasal mucosa, which can be a red herring towards AV malformations which are there inside as well. And these patients sometimes have history of epistaxis in the past. Stigmata of liver disease, you all know, splenomegaly, ascites, history of jaundice, alcohol, palmarism and so on and so forth, and sometimes rectal examination. But that's mainly for a lower GI cause of bleed, for piles and fissures and polyps in the rectal area. But if you see an examination, you find that the finger is smeared with black stools, that means the source of bleeding is much higher, and probably upper GI is the source of bleeding and not the lower GI. All the patients may just come with history of melena or maybe sometimes hematochezia without any upper GI symptoms. These are some of the other clues that you may get. I will skip that. So how do you differentiate whether the patient has bled from upper GI or a lower GI source? A common problem in day-to-day practice. So patient who has melena, it can be an upper GI source, it can be middle GI problem, or it could actually be proximal colon as well if the bleeding is slow. And sometimes clues of stomach pain or borborygmy tells us that the bleeding is more likely to be proximal. If somebody has hematemesis, then obviously the source is upper GI. But these are some of the clinical features. Age less than 50 predicts upper GI source more often. Melenic stools often tell you that the bleeding is proximal to DJ flexure, preferably from the stomach, because then acid acts on it and makes it black. And if you have done a renal function test and you have a blood urea creatinine ratio, then if this ratio is more than 30, it suggests an upper GI source of bleeding. A very important subtle clue. So whenever you do investigations, look at this part. Do we need to put a Ryle's tube or a nasogastric tube in these patients who have upper GI bleed? Why and why not? Why? Means it is useful in patients when you are not sure where the source of bleeding is and endoscopy is far away and you don't want to do that, or he is too sick to have an endoscopy straight away, or you want to differentiate. Then itself in the point of first contact or an emergency, you can place a Ryle's tube, and even if the patient has no upper GI bleed or hematemesis or even coffee ground vomiters, just placing this tube and looking at the aspirate will tell us. And if you have anything of red or black aspirate, then it obviously points to an upper GI source. It's very, very unlikely the person will have two sources of bleeding, upper GI and lower GI, simultaneously happening. Okay. And it also gives the placement of Ryle's tube, also gives a prognostic information. If you find pure blood coming in the Ryle's tube aspirate, it predicts very high risk bleeding or endoscopic lesion. And if the patient is stable enough, you can consider an early upper GI endoscopy. But if the Ryle's tube aspirate is black or brown in color and gets cleaned up after a few lavages, then you can be more reassured and plan an endoscopy next day morning if you happen to see in the evening this patient. However, I must tell you that a negative nasogastric aspirate, that means a clear aspirate, does not always exclude an upper GI source. Sometimes in about 1 out of 5 patients you may still find a source in the upper GI tract, but the aspirate is negative. Having said all these things, nasogastric tube is not mandatory. In current standard of care, if the patient is stable, you need not put a nasogastric tube unless it's needed for some other reason, and you can plan your endoscopy based on its clinical condition to confirm or exclude what is the source next day or depending on the convenient time. So the first take home point would be that patients who present with upper GI bleed must still be considered in patients with severe hematochezia. That means if they have pure rectal bleeding coming in large volume, patient can be bleeding from the upper GI source and not necessarily from the lower GI source. So if you have to do a pan endoscopy, start from an upper GI endoscopy first, even if your nasogastric aspirate up front is non-contributory. Moving forwards, once you have examined these patients, how do you clinically assess these patients? How much blood volume has he lost, or what is the percentage of total circulatory volume which has been lost? Can be assessed by these factors which are mentioned here, and based on the volume or percentage of volume loss, you can categorize them. If person has no drop in blood pressure or no systolic blood pressure especially, and no increase in heart rate, then it's all probability a class 1 severity of upper GI bleed. And if they happen to have a normal urine output and is looking fairly okay mentally, then these class 1 patients are generally stable, and a endoscopy schedule can be at a more convenient time. But as we go in the severity of class, which means more loss happens, which leads to more heart rate, which leads to more systolic blood pressure and orthostatic hypotension, and sometimes they can have decreased urine output, and as this increases further, they get hypoxia and decreased oxygen carrying capacity to the brain, and they have decreased mentation, and that suggests the person is sick and needs admission in emergency or ICU setting. So more severe loss means more upgradation of the clinical care at that point, and you cannot postpone such things. So how do you resuscitate these patients? The first time that you see in your emergency duty in the ward, emergency ward, is after assessing that patient is sick, or even if he is normal, it is better to admit them and put an intravenous line. A preferably large bore IV cannula is preferred, because you never know when the next bleed is going to happen. Before the endoscopy happens, if your second bleed episode happens, this can be a disaster also. So prevent that. Start intravenous fluids, and crystalloids, that is normal saline or ringer lactates, are much better than albumin or hemaxil and hydroxyethyl starch. So start with normal saline first. Anticipate the need for transfusion. Just because somebody has come just now with a bleed 6 hours ago and he looks normal hemoglobin wise, or pallor is not there, but he's bled massively, doesn't mean equally you have to start transfusion, because there can always be mismatch in history. Some patients hype their symptoms and say they had bled massively, but actually it may be a small amount which was mixed with the gastric contents or juice or water, and that volume which he vomited out was much more. So just do not base your transfusion requirements or fluid requirement according to what the patient says. Your clinical acumen is more important. So blood pressure, pulse rate, oxygen levels, urine output, and obviously fluids will go in, and with this you can titrate that. If he continues to bleed in the nasogastric aspirate or re-vomits, has a hematemesis again in the hospital, then your transfusion requirement will be based accordingly. It is good to keep blood ready, but transfuse only when the situation arises, which I'll tell you in the next few slides. If somebody has a hemoglobin of 7 and has come with a bleed, then I think it is best to start off, provided he was normal hemoglobin before. Mind you, a unit of blood increases the hemoglobin by about, hematocrit by 3% and hemoglobin by about a gram. So 1 unit raises 1 gram hemoglobin, but provided he stopped bleeding. But if he continues to bleed, then all this will leak out and hemoglobin would not rise commensurately. One important thing I would mention you here, that if a person has come with massive bleed within first 12 to 24 hours, hemoglobin may not drop, and so would be the hematocrit. And the reason for that is that if you look at this bar chart, the white part is the red part is the RBCs and the white part is the rest of the blood, the plasma and the other things. The moment he bleeds, everything drops down in equal proportion. So both the red part and the non-red part of the circulatory volume falls. So a HB and PCV taken in emergency would actually be same. And now you start IV fluids, so his white part would keep increasing and the red part would then be relatively low. So the red part is now the packed cell volume, which will drop after initial transfusion of crystalloids. So he comes in the evening, you give him a liter of fluids for 6 to 12 hours, you do his hemoglobin next day morning along with PCV, you find that the hemoglobin is dropped, but PCV probably has dropped more, which tells you that now hemodilution has occurred. And last but not the least is to correct coagulopathy if it happens to be there. So coagulopathy is present in patients either who are on anticoagulants for heart disease or neurological disorders, or patients who have liver disease who have coagulopathy as a part of the illness. So what should be the transfusion strategy? Now that you have found that the patient is sick and he has very low hemoglobin, should you rapidly transfuse fluids and blood to bring it back to normal, or you should be very gentle and slow? And so there's a study which came about 7 years back in New England Journal, which showed to compare the restrictive transfusion, which meant that the target of transfusion was to keep the hemoglobin between 7 and 9. If the patient had hemoglobin at admission was less than 7, whereas liberal transfusion was, the target was kept at 9 to 11 when that hemoglobin at presentation was less than 9. The primary outcome was all-cause mortality. So if you see here that the restrictive transfusion, that means you do not transfuse more and keep the hemoglobin below 9 or around 9, had lesser mortality compared to if you transfuse more. So just giving more blood does not make the patient better, it can be detrimental. Same goes for rate of further bleeding. So if you transfuse more, the risk is 10%, but if you have liberal transfusion, it can go to 15 or 16%. And overall complication rate can be high in both, but it is much higher if you give liberal transfusion. So be very cautious and judicious to use this precious commodity of blood. Remember, early intensive resuscitation reduces mortality. There is another study based on this, where in one cohort of patients who were observed, they had a standard of care resuscitation, but another group they had more intensive resuscitation. And the goal was to decrease the time to correction of hemodynamics. So you give too much fluid, improve the blood pressure so that the hemodynamics improve. That's the goal of any loss of blood or fluid should be replaced by replacement of fluid. So if the circulatory volume is maintained, that's the prime goal of all patients who come with GI bleed or any kind of volume loss. acute gastroenteritis and so on and so forth. Everywhere we have to replace fluid for fluid, and if the blood pressure remains normal, outcome is better. This was shown in this study, and they found that if you have an intensive resuscitation, it reduces the mortality. So in observation group where the resuscitation process was slow or much more conservative, they had more MIs and more deaths. But in patients who had a more aggressive resuscitation with fluids, even in patients who had heart disease, provided you give them carefully, do not fluid overload them, the risk of heart disease or MI and death from sepsis were much lesser. One more thing I would like to address here is what is the cause of mortality in patients who have peptic ulcer disease. It's very, very rare for a peptic ulcer disease, in spite of bleeding, to die from it. They die from more often from other causes. So these patients rarely bleed to death. In this cohort of more than 10,000 patients, the mortality overall was 6.2%. But if you see carefully in this graph, that these red is because of bleeding from the peptic ulcer. So these are all kind of deaths from 1993 to 2005. So over 12 years, they kept seeing patients who had peptic ulcer disease and those who died. If you dissect this mortality each year, they found that only this percent death was because of peptic ulcer alone, and rest of this bleeding was non-bleeding cause were the cause of death in these patients. So 80% of the patients will die because of non-bleeding causes, whereas bleeding contributes to only about 20% or lesser. So how do these patients then die? So what are these non-bleeding causes of mortality in patients who present with peptic ulcer bleed? And some of them are either they have a terminal malignancies, or they have a multi-organ failure which may have been precipitated or aggravated by bleed, but bleed stopped but the organ failures continued, or they had underlying pulmonary disease which worsened, or they had underlying cardiac disease. So other organ involvement is very, very crucial, and that's why any patient who comes with bleed and he has age more than 60 or has comorbidities in form of cardiac, pulmonary, renal, these become a high risk. So comorbidities are essential to be looking at these patients very carefully, and it may be a good idea to admit these patients so that you can improve these comorbidities simultaneously while you're taking care of the GI bleed, which is the primary cause for presentation. So that's my second take home point. Early resuscitative measures and supportive care are critical to reduce the mortality from upper GI bleed. What more? So moving forward, what is a risk stratification? So we have to identify, as I said earlier, that patients who have high risk and are likely to have adverse outcome, and if you find that they are high risk, then you triage them accordingly. Higher risk will go to ICU, less higher risk will go to HDU, and even lesser risk can go to ward, and patients who do not have risk can be sent back in outpatient and to be seen later. This also helps in triaging what is the appropriate time for endoscopy. So how do you do this risk stratification? There are various scores which tells this. For example, Rockall score tells us the risk or mortality chances in patients who present with bleed. There is an AIMS 65 score. This is not from All India Institute of Medical Science, but AIMS 65, which tells us mortality. And there is a Glasgow-Blatchford scores which tell us which are the patients who do not require endoscopy. So let me just expand this further. So in Rockall score, it is a validated predictor of mortality in patients with upper GI bleed. It has two components to it: a clinical component, which you can do in the clinical examination before you ask for any investigations, and an endoscopic component. In clinical component, you look at the age, whether it's less than 60, 60 to 80, more than 80, and so on, and each thing is given a score. Presence of low blood pressure or shock, presence of comorbidity, I highlighted earlier, and here they have said that patients who have cardiac is given as 0.2, but renal and liver failure have given higher weightage. Remember, so liver and kidney take precedence over heart. And then at diagnosis, endoscopy, if you find if it's a Mallory-Weiss tear or other causes and malignancy. So malignancy is given a higher point, a higher weightage, and if you do endoscopy and find an ulcer, and depending on the stigmata of bleed, a higher stigmata will give you more points. So higher the point, higher the chance of mortality. So if you add all these things together, the age, the presence of low blood pressure, presence of comorbidity, endoscopic diagnosis, and presence of stigmata on endoscopy. And based on that score, so as the score rises, the risk of mortality rises to almost 50%. So there is a chance of 1 out of 2 will die if they have very high score, and that's why you should be aware of it. The second score, which I said, is AIMS 65, which looks at AIMS stand for albumin, INR, mental status, systolic blood pressure, and 65 is the age. So all these things are common in most of the scoring. Albumin is a new thing which gets added on, and it said that this simple scoring system predicts that inpatient hospital mortality, what is the likely length of stay. The higher the score, more longer they will stay, and more longer they will stay, the cost incurred will be more. And this is the same thing. And last scoring is the Glasgow-Blatchford scoring, which came in Lancet 2000. It predicts a need for endoscopic therapy. The previous one told about the mortality. This one tells about the need for endoscopic therapy. And this is based on blood urea nitrogen, hemoglobin at presentation, both in male and female a little different, low blood pressure and other markers, which are again tachycardia, presentation with melena, presentation with syncope, hepatic disease, and cardiac failure. So you observe carefully, there is a lot of overlap between these in the scoring systems. The comorbidity is taken care of, hypertension is taken care of, syncope is again taken care of, and the hemoglobin also. So patients who have very low score of 0 or 1, they do not require urgent endoscopy. You can plan or schedule it later. But patients who have a mid-level score have a 50% requirement of endoscopic therapy, and patients who have a very high score will have almost 100% chance of endoscopic therapy. So when do we do an endoscopic assessment? As soon as the patient comes in, or can we wait? This publication has come this year in NEJM in April 2020, and this concludes quite clearly by saying that early adequate resuscitation is the key to outcome. So what I said earlier, this study re-emphasizes in 2020 also, that the moment a patient comes with massive bleed and has hypotension and hypoxia and neurological changes and so on and so forth, they just require fluids and blood transfusion. More fluid to bring up the blood pressure, and once the hemoglobin is around 7, you bring it to 9. So two things to be looked at. Urgent endoscopy means endoscopy within 6 hours of presentation to the hospital. It does not improve the overall outcome. Delaying the endoscopy to 6 to 12 hours may lead to lesser interventions and better outcome. So delay endoscopy and spend this time to improve the clinical condition of the patient. That's the important take home point. So urgent endoscopy is not required for lower scores. It may be required for higher scores, but after resuscitation. Let's move to the next agenda, which is the correction of coagulopathy during upper GI bleed. Mind you, platelets which are less than 50 or INR more than 1.5 or APTT higher than 1.5 and fibrinogen if it is done. If these factors are present, risks of bleed happen and you need to correct them, but some of them could be because of drugs which the patient may have been taking. So do we need to stop aspirin or clopidogrel which the patient has been taking for cardiac disease? So there is one trial which is comparing continued use of aspirin versus stopping aspirin and giving placebo, and they find that if you stop aspirin in a patient who has a pre-existing heart disease, recurrent bleeding can occur in about 1 out of 10. But look below, the mortality rate is only 1%, and that's mainly because of cardiac reasons. On the other hand, in the placebo group, that means you have withdrawn aspirin and given something else as a placebo, Recurrent bleed does come down by half, but still it is 5%, but patient still dies, and that's not fair. That's because you have withdrawn the aspirin, which is supposed to be a very crucial medicine for the patient who have significant heart disease or ischemic heart disease. So continue your aspirin. Maybe you can stop one of the two drugs if he's on two drugs, or if he has a very severe stigmata of bleed on endoscopy, then you can stop one for a few days and restart it back quickly as soon as he recovers. So this is a very important take home point, never to stop antiplatelets unless justified, and if you stop it, stop for a very short while and bring it back quickly to the normal dose, because peptic ulcer disease heals very fast. So those patients who are on primary prophylaxis, that means they don't have any heart disease but they have a high risk because of diabetes and age and atherosclerosis and hyperlipidemia, you can hold aspirin in them because you don't have a proven heart disease in them, and you can resume back on discharge. But those patients who are already taking and have a proven heart disease, that is a secondary prophylaxis, if we have a low risk ulcer, I will tell you what is low risk ulcer later on, you can continue the aspirin and you can continue your dual antiplatelets. So if aspirin and clopidogrel is going, you can continue that combination, or even aspirin alone is going, you can continue it with your proton pump inhibitors. But those patients who have high risk ulcer, that means they are spurting or have a clot adherent or have a visible stigmata of a bleed, there you have to stop it for a few days and resume by day 3 or day 4. And if your dual antiplatelets are going on, make it only one drug. And you can also do a relook endoscopy to see that high risk has become low risk, and then you can liberally start the antiplatelet agents. So take home point number 4 is aspirin should be resumed immediately after endoscopy if the risk of rebleeding is low. Okay, but if the risk of rebleeding is high, then reintroduce aspirin after stopping for 3 days. What about giving medicines before you do endoscopy? That is pre-endoscopic pharmacotherapy. In patients with non-varicose bleeding or in a proven varicose bleeding also, we can start off medicines. In peptic ulcer disease, we can start high dose PPI intravenously as a bolus or as an infusion drip. The rationale for this is that it suppresses the gastric acid, and this facilitates the clot formation. If acid is high in the stomach, the clot is not formed easily, and even if it is formed, it is not stable. But in patients who have acid suppressed or an alkaline pH, then the clot forms faster, and also it stays longer and stable. And this would help you in delaying your endoscopy till the time patient is stabilized. So if you do not know it's a varicose bleed or a peptic ulcer bleed, it is wise to give PPIs. It does no harm in patients who have cirrhosis or any other cause of portal hypertension which causes bleed. But if it's because 50% can be peptic ulcer and 50% can be varices, unless you have a prior history of a patient having a varicose bleed. Mind you, even cirrhosis patients can have a peptic ulcer, which is more common in them than the normal population. So giving PPIs is safe and should be given, so that by the time you reach endoscopy, it actually helps, it downstages the lesion. And that's very interesting. So a high grade lesion becomes a low grade lesion by the time you do endoscopy, say 12 hours later. And this also decreases the need for endoscopic therapy, and however it does not show any improvement in rebleed or not requirement of surgery or mortality. But nevertheless, my first two target points are achieved, that is, it downstages the lesion and helps in the clot, which stabilizes and kind of tamponades the bleeding source. So early endoscopy within 24 hours is recommended, as has been found in the recent NEGM trial, in most patients who have acute upper GI bleed, not immediate and not urgent. It achieves prompt diagnosis, provides risk stratification, and you can do hemostatic therapy in patients who have high risk lesions. I would also like to emphasize that about 4 out of 5 patients who have a bleed will stop on its own. Whatever you do or do not do, most bleeding stops. So what is the risk of rebleeding? In active bleeding, obviously they are continuing to bleed unless you stop it. They would stop after some time, but again can rebleed. So if you find endoscopic the spurt is happening, you do something, but there is always a risk of happening again. Non-bleeding visible vessel. This is a very important thing, and 50% of these vessels will rebleed because now the surface mucosa is missing in these ulcers. Presence of adherent clot is a variable outcome. So there is a school of thought which says that remove the clot and then find the bleeding source and tackle at the same time for index endoscopy. But the last two things are very low risk features of a rebleed, that is just flat pigmented spot or a black spot, or if the ulcer is just white, clean based. And these are the classification of peptic ulcers. Class 1A is when you find an active spurting bleed within an ulcer. Class 1B is bleed but it's oozing and not spurting out. Class 2A is a visible vessel, Class 2B is an adherent clot, Class 2C is a flat pigmented spot, and Class 3 is clean base. And let me show you the pictures of them. This is an ulcer with a visible arterial bleed. Most ulcers bleed from arterial source, especially the gastroduodenal artery which is present in the duodenal cap. This is a large ulcer with a visible vessel here. This is a large ulcer you can see, but now surfaced covered with a clot. This is a white ulcer with a small pigmented spot. So this would become this in a period of day or two if you continue to give PPIs. But there is always a risk of bleeding in about 40 to 50%. And this has now totally a kind of white base, means there is no active stigmata of recent bleed, and this can just be treated medically. And if you see overall, this type of ulcer with clean base constitute almost 50%. The dots are about 1/4 and rest of them contribute about 1/4 altogether. I'll skip this. I just want to share some videos here that if you do an endoscopy and you find a bleeding vessel now, as you can see a spurt happening intermittently. So you clean it up well and then pass a sclerotherapy needle inside and inject adrenaline 1:10,000 dilution all around this lesion. So in 4 different directions, if you inject 5 to 10 cc of adrenaline at different points, that the bleeding vessel gets tamponade below, and that allows you to now see it more carefully and you can follow with another therapy in the same time. So just adrenaline injection will stop the bleed temporarily, but there is always risk of rebleeding happening. So it's better to combine two things together. This is an ulcer with a visible vessel, another picture. This is an ulcer with little pigmented spot. This is an ulcer with clean base. So this will not bleed again. This is very, very unlikely to rebleed again. But the first 2-3 that I have shown would have a chance of rebleed. So low bleeding risk in these two categories, and no endoscopic therapy is required if you see this in endoscopy. What are other methods? Apart from epinephrine injection, we can also give thermal electrocoagulation by a heater probe or a gold probe, or we can use mechanical accessories to tamponade or block these vessels, and these are usually various types of clips. And mind you, these are 3 different methods, but combination of more than one is always better than single alone. So inject with either thermocoagulation or clips with epinephrine injection. These are various types of thermal coagulation which is available: heater probe, bipolar probe, YAG laser, APC. Mechanical is in the form of hemoclips or over the scope clips, and sometimes banding also of sedulophobes lesion. Another example over here, this is a bleeding vessel. You see a jet of blood coming out, and this is mainly because of a vessel which is below this iceberg. It's an iceberg phenomena. Big vessel is there below. So when we inject adrenaline, we inject all around so that this vessel gets compressed by the submucosal injection of adrenaline. That tamponade, this tamponade causes decreased flow through it, and this reduces the spurt. and once you reduce the spurt, then your vision becomes better. After clear washing, then you can actually put a clip directly here. Or a thermal coagulation can be done. This is injection with co-aptive coagulation. So if this black is a blood vessel and this is the heating probe, you press over there, a firm pressure is required so that this area becomes totally white. This charring actually causes burning of the vessel wall, and which causes stoppage of flow in the underlying vessel, and then that heals with scarring. So that's a more definitive or a permanent kind of a treatment plan. So first you inject, this is a visible vessel, inject all around, and then you have a thermal contact directly on top of it. And mind you, I repeat again, combination treatment is better than either alone. But if you have nothing, just simple adrenaline injection would be good enough, and you can get ready for the next episode of bleed by arranging the other accessories which are missing in your kit. The other accessory that we use is mechanical clips, which are mechanical hemostasis agents. There is no tissue destruction, and this can be applied repeatedly, or many clips can be applied depending on the size of the lesion. Let me show you an example here. This is a patient who has come with a bleed with a large clot adherent on a large ulcer. So at the time he is not bleeding, but it is wise to use a cold snare and remove the clot just like a polyp, wash the underlying area, and then see where the bleeding is coming from, because no bleeding from an underlying clot gives you a false sense of security, and then the patient can bleed later on. You cannot keep doing endoscopy every day to see whether there is bleeding or not. So it may be a good idea to tackle the problem more definitely in one setting. What are the new modalities in peptic ulcer bleeding? There are now closure devices. Various new kinds of clips are available which can be rotated, expanded, and can be fixed according to the contour of the ulcer, and especially if the angle is not very good to apply, you can actually move these clips in different directions. So rotation adds to the value. These are the clips, different types of clips called as OTSC clips, which give more deeper coaptation and fixity, so that the vessels which are deeper down can also be taken care of. It is also good for patients who have a scarred ulcer, whereas the regular clips do not go very deep down and can cause sometimes damage to the vessel without actually relieving the bleeding, whereas this one can. So let me show an example here. This is another ulcer bleeding, peptic ulcer bleeding. So OTSC, or the over the scope clip, is just loaded like a band which we use for varices. This is a single clip, fits on a transparent hood. You go to the ulcer and then apply suction over there. During suction, sometimes blood also can get sucked in, but don't worry, once you are there, keep sucking. A gentle, firm suction should be applied, and the moment you see that some of the mucosa has got sucked inside the cylinder, then you can fire. And once you fire, it kind of claps the underlying vessels and seals it off. And here you see it's very nice polyp kind of a raise. This is much more superior than the standard clips, where not one but sometimes 2 or 3 clips may be required, whereas here only one OTSC would actually solve your problem if placed perfectly. And this is a study from Mayo Clinic which showed that patients who had interventions with this had a much more sustained benefit of a peptic ulcer bleeding. Endoscopic suturing is another method by which this is a very new thing, still finding its place because it's not available at most centers. The suturing device, which is actually borrowed from bariatric surgery, or where you suture the stomach and make it smaller. Hemospray is another exciting method of stopping a bleed, and this actually came from the army. The US Army, when working in the Middle East in the Iraq war, when they used to get these injuries on the limbs, and bleeding was torrential, they were using this powdered spray on those soldiers, and that used to stop the bleed. So the loss of blood was minimized, and the same powder has now, it's called TC325, which is available in a canister form. It's a very innovative method of delivering this, and this catheter is then passed through the endoscope, and using a pump you then flush powder inside. For example, if you see it here in this animation video, this is a bleeding peptic ulcer. Here comes your endoscope, catheter comes out through it, and once you're in a good position, then you spray all over this powder. This powder seals off most surface oozing vessels, venous bleeds, and even arterial bleeds stop with it. Animal experiments have shown that if you cut the femoral artery of an animal, and that torrential bleed also can get stopped by these hemospray. So it's quite effective, it stays there, but again it may not be a permanent kind of a stoppage of bleed, because after some time this powder may get loosened and get dislodged. So you can, it's an emergency procedure which will tide over the crisis, and then you can follow with a more definitive procedure later on. In a real life scenario, let's look at here. This is an ulcer bleeding which is happening. Here comes the catheter from which the powder would come out. You can move your endoscope around and spray so that the whole surface of the ulcer can get coated with it. What about the last part of it is what the post-endoscopic management. Patients with low risk ulcers can be fed promptly, and they can continue on oral PPI therapy and can be discharged. Those patients who have required endoscopic therapy, that means they had a high risk ulcer bleed, should continue to receive PPIs either intravenously preferably, and once they start taking oral, you can switch to oral as early as possible, and this reduces their 30-day mortality rate versus placebo. Has been seen earlier, and some of the experts have written in their editorials that endoscopic therapy significantly reduces further bleeding, the need for surgery comes down, and also mortality improves in many patients with bleeding peptic ulcers. It is recommended as the first hemostatic modality for patients with bleeding peptic ulcers. However, bleeding can reoccur in 1 out of 5. So that's why these patient acid suppression should be given and continued, so that the high risk become a low risk ulcers. As I said earlier, so in vitro studies have shown that high gastric pH facilitates platelet aggregation and stabilizes the clot, and acid suppression therapy actually decreases rebleed and also the need for surgery. I will skip these few slides. If nothing works, then you'll have to call back your surgeon and intervention radiologist, and most of this bleeding which are coming from the artery can be visualized at the time of angiography, is spurting, or if you have a bleeding and you tried clipping, that clip, even if it is falsely placed, gives a clue that where the source of bleed is coming from. So if you have peptic ulcer disease, you did endoscopy, you placed 1 or 2 clips but still not stopped bleeding, you call the intervention radiology friend, but the clips that you have placed, in spite of not working, are now your clue for intervention radiologists to target where the likely site of bleed is. So gastroduodenal artery is the commonest source of bleeding, and that area they can embolize by glue or coil. Last but not the least, that we need to treat these patients with H. pylori therapy, because most of the peptic ulcers have an underlying H. pylori, and if you treat them with H. pylori therapy, then the rebleed rates are much lesser, and those who have not, 1/3 can bleed. I would finish off here by saying that mortality in patients who had a non-varicose upper GI bleed is related to age, comorbidities, stigmata of recent bleed found on endoscopy, and hemodynamic instability at the time of presentation, which could not be improved upon by giving enough fluids. So these 4 factors are very important: elderly patients, patients who have heart disease, especially liver and kidney, and also heart. And if you happen to endoscopy at some point of time and you find stigmata, high stigmata, we issue endotherapy, but still they carry risk of rebleeding. and those who have low blood pressure or hypoxia or anoxia causing symptoms in the beginning. So the take home points would be all bleeding peptic ulcer eventually stop, and majority of non-variceal bleeding will stop spontaneously with the patient being alive, and early resuscitative measures and supportive care are the key to reducing the morbidity and mortality. Mind you, the bleeding happens, and the death in patients of GI bleed, as showed earlier, is more because of non-bleeding causes, that is heart disease, kidney, tumor and so on and so forth, versus just pure bleeding alone. Thank you very much for your kind attention. I would be happy to take any comments and questions from any of you. Okay, so there is a question over here which asks about whether to use, how do you decide whether it's a varicose bleed versus it's a non-varicose bleed. This topic was mainly for the varicose bleed, for the non-varicose bleed, but varicose bleed is equally important, and you will have some stigmata of portal hypertension or cirrhosis, that is non-cirrhotic portal hypertension or cirrhotic portal hypertension. Ultrasound would also give you a clue, which should be done as early as possible if you don't have a prior reports, and a quick endoscopy after stabilization will tell us presence of esophagus and gastric varices. If it's only esophageal varices, just banding with multiple band ligators will be good enough, but if it's a gastric varices alone, then glue injection into the gastric varices solves the problem. Those patients who have both esophageal varices and gastric varices, it is look for the stigmata of bleed on these varices. If it's only on gastric varices, just glue injection would be okay, and banding can be done same sitting or later. But if esophageal varices have red color signs, then you can do banding first and glue injection later on. There's another question which says that if endoscopist is available round the clock, do you recommend endoscopy as soon as possible? I would still say no. Most important is their resuscitation at the time of presentation, and their stability should be the first thing that should be taken care of. Okay, and once even if the blood pressure is normal, put a white bore line, give a PPI, make them stable, and then do an endoscopy. If it can be done in the working hours, fine, but I would say calling an endoscopist in the middle of night when the patient is stable, it's better to do it next day morning when the clot is stable, bleeding stops, and high risk ulcers often become a low risk ulcers which may not require any endotherapy. I think we have overshot the time, and we can take the questions and comments as and when they come. Yeah. If okay, that's an interesting question. Should we use a gastric emptying agent to? That's a very important point. So, along with the proton pump inhibitors, it may be good to empty the stomach before endoscopy is taken care of. So, metoclopramide or any kind of gastric emptying agent, erythromycin or lesuride, levosulfide, can be given a few hours before. So, at the time of endoscopy, the patient is, although fasting, even the blood clots get emptied, and that gives a better vision. And during endoscopy also, you should have a pump ready so that you can clean up the gastric mucosal surface to carefully look everywhere, especially in lesions where there is no obvious source found, which means the duolephoid lesion. And some of these vascular lesions, once the patient becomes anemic, are not very obvious, and they become more obvious once the hemoglobin becomes normal. And that's the reason for giving a transfusion sometimes before to bring around 9. So a patient, you do endoscopy at 5 or 4 hemoglobin, one, he has higher risk of sedation, he will be very restless, you will not be able to see endoscopic properly. But once you given transfusion and stabilized him, it will be more relaxed endoscopy for you, and the tiny lesions which bleed torrentially can then be picked up. and I am talking about the delufoids or some vascular lesions which can be missed out in other settings. When should we rescope the patient with high risk ulcer? I think high risk ulcer means those who have a visible vessel with ooze or spurt or adherent clot where we have done something. It may be a good idea to do an endoscopy 24 hours to 48 hours later, even if there's normal, before you actually send them home. And this would be a reassurance both for you and the patient, because now you are sure that everything is stable. Because melena would take 3 to 4 days for the color to clear up, and hemoglobin sometimes actually drops when you are giving more crystalloids. I said earlier, the PCB may drop, the hemoglobin may drop next day or 2 days later, but actually the bleeding has stopped. So not to worry, follow the clinical symptoms of the patient. So another question which comes up is, when you summon anesthetic help in endoscopy treatment of GI bleed? Very important question. I think that's important. I think these high risk patients, you should always have the anesthetist colleague with you, because not only they help take care of the vitals when you are concentrating on the endoscopy part of it. Try not to give sedation yourself and endoscopy yourself. You cannot do multitasking. You look at one part and your colleague looks at the other part. So transfusion, injections, bolus fluids, looking at the oxygen level, hypoxia and sensorium guides us better, so that you can concentrate on stopping the bleed. The bleeding tank should stop. What about the role of adrenal spray and not the injection? Is it of any help? I'm afraid, Taha, this is not very useful, although some people say that spray also helps in some kind of a mucosal vessels contracting, but those superficial vessels are very small. It's a deeper vessel which is bleeding, and the spray will not reach there, and that's why we need to give a submucosal injection to cause tamponade, as I showed in one of the cartoons. What is the opinion to use tranexamic acid in peptic ulcer disease and upper GI bleeding? There's a question of these so-called pro-clotting agents are still experimental. They are not the standard of care for patients who have peptic ulcer bleeding. But if nothing works and the patient continues to bleed, then you can use these kind of agents which help in clot formation and clot stabilization. But they are not the standalone or treatment for peptic ulcer disease. Someone used to ask about role of cold washed saline in Ryle's tube insertion, nasogastric insertion. I think that's an outdated method of treatment. Just placing a Ryle's tube and giving cold saline lavage used to be a standard of care more than 20 years back, but no longer used. But sometimes if we have placed a nasogastric tube, you can use it for cleaning the stomach before endoscopy. At the same time, you can give a prokinetic agent which helps us in cleaning the stomach. Can you just open this, please? So cold saline is not very useful. Standard water or standard saline is as good to clean up the stomach. Cold saline does no extra benefit. I think we'll wind up here, and you can send questions and comments later on to aighospitals.com. Thank you very much for your kind attention. Stay safe, stay happy.